We shall now go on to our next speaker. Dr. Viney Gupta is a professor of ophthalmology from RP Center, the glaucoma services, and he's going to tell us about how to avoid misdiagnosing normal tension glaucoma. Yes, doctor, can you unmute yourself?
So I hope my screen is visible, and can you see my screen?
Yeah,
Yes.
but you need to do on the presentation mode, full.
Yeah.
Play.
Yeah.
That's right. Okay, carry on.
So thank you, Dr. Chitra, for this invitation. I think it's important to have glaucoma when you're dealing with neuro-ophthalmology, because a lot of these cases actually get misdiagnosed, and I will show you how. But at the same time, I would like to say that since we do not have a clear definition at present of what is normal tension glaucoma, so therefore it is really not very surprising that you tend to misdiagnose some of these cases. In fact, the way we diagnose normal tension glaucoma is that it is a glaucomatous optic neuropathy in the presence of open angles and normal intraocular pressures. So classically, how we distinguish a glaucomatous optic neuropathy from a non-glaucomatous optic neuropathy. The classical signs are that a non-glaucomatous optic neuropathy would generally have a very severe visual field loss, which will happen early in the course of the disease. And you can classically see an area of pallor, which is more temporal, and it is associated with a centrocecal scotoma, which is generally has a poor correlation with the amount of the cupping or the amount of pallor sometimes. So therefore, this is what is classically taught. However, I will take you through scenarios where patients presented with what looked like a glaucomatous optic neuropathy, but turned out to be a neurological cause. So in this particular case, you can see that there is a very large cup disc ratio in this gentleman who presented with normal intraocular pressures, but you can see that there is some thinning of the neuroretinal rim here. Now, this patient was started on treatment for glaucoma, but what you can see apart from that is that there was a scotoma which corresponded to that area of thin neuroretinal rim. So now that it was not progressing, so we ordered an MRI, and the MRI showed that there was a gliosis which he had had previously at some point of time, and this was manifesting as a scotoma. So therefore, here we could rule out this patient as having glaucoma primarily by doing a neuroimaging. But there are other cases where the diagnosis could be even more perplexing. And you can see here a young girl who was, a young boy who was brought here with advanced glaucomatous optic neuropathy, which you can see hardly any neuroretinal rim left in him. And he again was diagnosed as a normal tension glaucoma. He was started on medical therapy for glaucoma. He had low teens. And as we followed him up, we were seeing that he was progressing. So everything looked like a glaucomatous optic neuropathy, but there was something amiss. Was it a burnt out glaucoma? Was it a normal tension glaucoma in a young person? Or was it actually a primary optic atrophy? So then we went back and looked at his father's optic disc, and we found that the father also had some kind of pallor of a neuroretinal rim. But this was very different kind of an optic disc from what his son had. So despite the fact that both the father and son were having some amount of optic atrophy, the features were very different. So this brought us to something that is very provocative and has been written about before, that probably normal tension glaucomas are actually unrecognized hereditary optic neuropathies, because both of the diseases have a slow, insidious loss of vision. Both are familial. Both can have a disc morphology which is similar with paracentral visual field defects. And finally, the most importantly is that the underlying pathophysiology in both the cases is a mitochondrial degeneration. So actually, they are both kind of similar diseases. This was another case in support of the similar situation. A mother who had an arcuate scotoma, typical arcuate scotoma of glaucoma. And when we looked at her optic disc, the optic disc also on the face of it looked glaucomatous. If you carefully see, there is some amount of neuroretinal rim pallor, but more or less there is a large cup also in the mother. We then went on to look at the daughter, because the mother had got the daughter with her and wanted her daughter to be examined. The daughter also has an inferior nasal step, typically glaucomatous. And when we looked at the daughter, she does not have that kind of a cupping, but she had some amount of pallor of the neuroretinal rim. And therefore, this was again a case of a hereditary optic neuropathy. So this is how you can differentiate. If you have families come together, you can screen the other relatives of the other family members to rule out that are you dealing with a glaucoma or are you dealing with a hereditary optic neuropathy. There could be another scenario where a glaucomatous optic neuropathy is misdiagnosed because there is something else going on. For example, in this young female who was on treatment for normal tension glaucoma, and you can see that there was a typical defect in the RNFL that she had. She had a thin neuroretinal rim, some amount of peripapillary atrophy, and there was a visual field defect very close to the fixation. But apart from that, she also gave a history of having cold hands and feet. She had migraine, she had a low body mass index, a low blood pressure, and this ran in the family. There were other family members who had a similar kind of a picture. So when we went back and we looked up and we found that this was what was classically known as a Flammer syndrome. This is a vasospastic syndrome which leads to all of these symptoms. So migraine, having cold, vasospastic hands and feet is also a part and parcel of this whole disease, and normal tension glaucoma or optic neuropathy could be part of this syndrome. So there are other syndromes also that we are well aware of, like the obstructive sleep apnea syndrome and empty sella syndrome, and those compartmental syndromes of the optic nerve who may have optic neuropathy, which resembles very much like a glaucomatous optic neuropathy. Finally, we have situations where the patient has an optic neuropathy, but it may be concomitant with another neurological disorder that is going on. Like in this patient who was diagnosed with angle closure glaucoma, had advanced glaucomatous optic neuropathy, but after treatment and after his intraocular pressure was well controlled with surgery, despite that, he kept on progressing. So you can see that the visual field defect is going on right till the center, till the central visual field in one eye is almost gone. So we could not really explain why he was progressing despite the fact that his intraocular pressure was absolutely normal. And so we decided to go ahead with doing a neuroimaging, and we found that there was a pituitary adenoma which was actually causing this. So this was just an incidental finding which we could pick up if we had done a neuroimaging for. So to summarize, actually the normal tension glaucomas, you can only diagnose if you have a very high index of suspicion, and you need to do a battery of tests. Actually, you need to do a central corneal thickness, you need to do a diurnal variations to see the intraocular pressure fluctuations. It's good to examine the other family members actually before you make a diagnosis and to differentiate it from hereditary optic neuropathies. The best is if you can draw pedigree charts and keep them in the files of these patients. Of course, it goes without saying that you have to do neuroimaging, because actually it is a diagnosis of exclusion. You need to exclude out everything before you diagnose a patient as a normal tension glaucoma. Thank you.
Thank you. Thanks a lot, Dr. Vinay. Very good talk.